Welcome to Global Connections with Robert Siegel, Navigating the New Normal, presented by the American Friends of Rabin Medical Center. Our monthly Leaders Forum addresses vital issues facing society and the economy, real estate and medicine, technology and science. My name is Dr. Joshua Plow. I'm the Executive Director of American Friends of Rabin Medical Center, AFRMC, a 501c3 National American charitable organization based in New York City. We at AFRMC represent Israel's premier hospital, Rabin Medical Center in Petach Tikva in Greater Tel Aviv, the leading institution named in honor of Prime Minister Yitzhak Rabin. The hospital is a model of coexistence, as it serves 1 million patients annually from all ethnic and religious backgrounds with the same compassionate care. The hospital's centers of medical excellence include oncology, cardiology, emergency and trauma, genetics, women's health, and organ transplantation. Please support our mission with a donation of any amount. Join our community of friends. Visit American Friends of Rabin Medical Center online, afrmc.org, via our website and social media outlets, on Twitter and Instagram, LinkedIn and YouTube, in our Facebook page and discussion group. This free program depends on your audience support. So thank you if you can contribute any amount. Our host and moderator for Global Connections is Robert Siegel, former host of All Things Considered on National Public Radio for 31 years. Over the course of an hour each month, Global Connections features guests who Robert Siegel interviews as they explore important issues in our world. Today's Global Connections topic is, I have cancer in my family. How genetic testing can prevent breast, ovarian, and prostate cancer. Thank you to our very special guest, Dr. Kenneth Offit, Chief of Clinical Genetics Service at Memorial Sloan Kettering Cancer Center in New York City. Dr. Susan Domchek, Executive Director of the Vassar Center for Brca at the University of Pennsylvania. And Dr. David Margel of the Institute of Urology and founder of the male Brca clinic at Israel's Rabin Medical Center. And now, Global Connections with Robert Siegel.
Thank you, Josh. October is Breast Cancer Awareness Month. And for the second year, we at Global Connections are devoting this month's panel to that subject, in particular to breast cancer, as well as ovarian and prostate cancers that have been linked to genetic causes. For some Ashkenazi Jews, Jews with roots in Eastern or Central Europe, every month should be Breast Cancer Awareness Month or Prostate Cancer Awareness Month. Ashkenazi Jews are far more likely than others to carry a gene, a Brca gene it's called, that raises the risks for them of getting those cancers. Ashkenazi Jews are by no means the only group who carry a gene that puts them at higher risk of cancer. French Canadians and Poles are just two groups among many others that are at heightened risk. How much do we know about the genetic causes of some cancers, and what is current research telling us? And how much does genetic testing improve our chances of avoiding or surviving cancer? Well, we have three medical experts on hand, and we hear from each first, and then we'll have a session that will include your questions, which you can submit using the Q&A button at the bottom of the screen. We start with a pioneer in the study of the genetic links to cancer. Oncologist Kenneth Offit is Chief of Clinical Genetics and holds a chair in inherited cancer genomics at Memorial Sloan Kettering Cancer Center in New York. In the 1990s, Dr. Offit's team identified the most common mutation on the BRCA2 gene that's associated with breast and ovarian cancer among Ashkenazi Jews. He went on to find other mutations that increase the risk of colon cancer and prostate cancer. Ken Offit, thanks for being part of this panel today. In a moment, I'd like you to explain just how Ashkenazi Jews developed a connection to this mutation on the BRCA2 gene. But first, I'd like to know just how much more likely are people of Ashkenazi descent to carry this mutation than, say, a random sample of Americans?
It's a pretty incredible story and not one that is pleasant to tell. It's one that's better told with graphical pictures than it is with words. But the bottom line is that this rare mutation became common over the run of centuries, 4 to 5 centuries, from 800 AD on up really to 1500, when the world population of Ashkenazi Jews was on the verge of extinction, on the range of tens of thousands through the Pale of Settlement in Europe. And in these small pockets of individuals that were persecuted and killed, randomly, one person survived that had a rare mutation. The mutation I found is just a single base pair change. It happened by accident. That 1 in a million person now is part of a community that becomes much smaller. And he or she is now not 1 in a million, but 1 in whatever the size could be, 5 or 10. And then around the 1700s, the Ashkenazi population expanded tremendously in Europe. Catherine the Great had something to do with this, and that rare mutation became very common. So the population went through a bottleneck. A rare event happened that became magnified as the population grew, and all of us today are sort of descendants of that small population that existed in the Pale of Settlement for hundreds of years, and we bear, as it were, the sort of the genetic baggage of those times. Not only this one mutation, but in fact, over the period of time, we discovered a dozen or so of these mutations associated with many different types of cancers that are more common in the Ashkenazi Jewish individuals of that ancestry.
So our ancestors back in the time of the Black Death were very small in numbers, and they also intermarried, and we're their descendants. Would one find in other similar groups around the globe other mutations that might lead to cancer or to other conditions?
So, as you pointed out in your very nice introduction, the Jewish experience in genetics is not unique. It's just that we came to this slightly different way. Typically, for example, you mentioned the French Canadians. Typically, you have someone from France goes to Montreal with a rare mutation by chance, and then that mutation sort of has a new home and a limited population to grow. And so you have a common French mutation in Montreal or a Dutch mutation in South Africa, or typically in the Scandinavian countries, you have mutations, Viking mutations in Ireland and in Finland and in Sweden. You have little islands, actually, that by themselves become island populations. In the Jewish experience, there was no physical island. It was a geopolitical island, right? And with persecution that led to it. But the effect of these mutations is magnified in these populations. And we do see, for example, breast cancer mutations of a gene called CHEK2, which is quite common in Northern Europe. We see a mutation of a gene that causes many types of cancers of the breast, but also leukemias and brain tumors, very common in a very small area of South America. So this event, these founder mutations, we call them, have happened many, many times in genetics, and not only in cancer genetics.
How important is it to confirm the presence of the gene in healthy people, let's say?
Well, this gets into, I think, what is your topic of interest today, which is the screening for these genes. And some folks believe that we should be doing screening the entire population for every possible gene that we can think of. And we've reached the point where that can actually be done on a sort of financial basis. The cost of doing this genetic sequencing, DNA sequencing is much lower. But when you do that, you get results that can be difficult to interpret, variations. And that is a concern and takes a lot of time to explain. In populations, though, where you have single mutations, like these ones that we discovered in the 1990s, why not just test or offer for testing any individual with one Jewish grandparent, the testing for these founder mutations? We thought of doing this back in the 90s, but there was pushback and concern that this would be stigmatizing in the community. And so we held off. And only recently, with the rise of direct-to-consumer testing and some of the sort of excesses, I would say, of this type of availability to individuals who might not have been the best prepared to receive it, we decided to offer this screening to any individual of Ashkenazi background in a study that we've just completed and that Dr. Domchek was a leader in with colleagues at Harvard and UCLA.
You mentioned to me one way in which you think testing might be improved by using what you call cascade testing. What does that mean?
Well, it's very important in any genetic condition to offer testing to individuals in the family who also could be affected. So, for example, in this study that I was mentioning that we just concluded, which offered this testing to individuals who are of Ashkenazi ancestry, to our surprise, over 50% of the individuals had some knowledge of a mutation in their family. And it's called cascade testing, which implies a waterfall, but I wouldn't call it that. It's much more like sort of whitewater canoeing, I think. It's difficult to get individuals who know there's a family mutation to be tested for it. And that cascade testing is a point of great interest for many of us right now, because we believe if we could just increase the testing in families for mutations that they're distantly aware of, we could really make a major dent in the burden of hereditary cancer in the United States and around the world. So that's what cascade testing is. It's just familial testing.
Are you saying people in the family who are distantly aware of a genetic issue, or distantly aware of breast cancer in the family, say, or prostate cancer?
Well, the family history, is portable. You don't, anyone who knows their family history can get tested and insurance will cover it based on family history. And that's, anyone can document that. But insurance will also cover if for example, that you have, a cousin that has one of these mutations, or a parent or a sibling. And so the cascade testing refers to that. Okay, it's the knowledge of the test, not the family history. The family history is our old-fashioned way of doing things, but the genetic information is there. And many individuals are aware of it. But more importantly, many individuals, when they're tested, can reach out to family members and let them know about it. And that's what we're working on right now, as a way to expand this information, not only within the Ashkenazi Jewish community, but among all communities where there are mutations that have been discovered.
Well, Dr. Offit, thank you very much. Please stick with us for the Q&A session that'll be coming up in 15 or 20 minutes. It's been good talking. We're now going to turn to Dr. Susan Domchek. She is executive director of the University of Pennsylvania's Basser Center for BRCA. She's also a professor of oncology at Penn, and she took part in our webinar for Breast Cancer Awareness Month a year ago. So welcome back. Good to see you again.
Much. Thanks for having me.
And first, what's new? I mean, since we spoke last year, I mean, what interesting studies have there been that have taught oncologists something new about detecting or preventing cancer?
Well, one of the most exciting things, and we talked a little bit last year about the fact that oncologists have been developing targeted therapies for BRCA1 and 2 mutations. So we've had FDA approvals for drugs called PARP inhibitors for metastatic breast cancer, for ovarian cancer, for metastatic pancreatic cancer and prostate cancer. And these drugs do help treat cancers, although they largely do not cure them. And so one of the most important things is whether, if you could bring these drugs into an earlier setting, whether you could actually cure cancers. And so in June of this year, we presented a study where women and some men with early stage breast cancer that was at high risk of recurring, meaning coming back outside the breast, went through all their usual therapy, but then either took one of these PARP inhibitors, something called olaparib, for a year versus taking a sugar pill. And we were able to show that taking olaparib significantly reduced the chances of their cancer coming back outside the breast. And we also were able to gain information in that study about the side effects. How harmful are these drugs to patients? And what we found is that they're generally pretty well tolerated. This not only moves things up in the algorithm for the potential that maybe we could really cure some of these breast cancer patients, but it also then starts to raise the question about whether or not these drugs could someday be used for prevention in the first place, meaning giving these drugs to prevent cancer from developing at all. We're not ready for that yet, but this study is a step in that direction.
A vaccine, I mean, in theory.
That is a different approach. This is what we call chemo prevention. We don't love to use the word chemo here. We just use that just means drug. So pharmacological prevention might be a better way to think about it. We also do have a study that we have started looking at vaccine to prevent cancers in BRCA carriers. Right now, we are in the stage where we're, again, giving a vaccine to BRCA1 and 2 carriers who have early stage breast cancers or other cancers, with the goal, though, of treating 28 patients who have not had cancer with this vaccine. This is a small study just to show that the vaccine approach is safe and that it generates an appropriate immune response. If we get those data, then we would take it to the next step to start looking at whether or not this truly prevents cancers. That takes big studies. It takes a lot of hard work, but we feel that's the way to go.
This is still very much at the experimental.
Correct. Both. Both of there are 3 approaches that are really actively being explored for prevention right now. Again, this approach for vaccine strategies, which is very early. The idea that maybe we could use a PARP inhibitor, also very early. And a drug called denosumab, which is a bone strengthener medication, which has been shown in preclinical models to decrease BRCA1-related breast cancers. So there is a very large international trial of BRCA1 mutation carriers who will be randomly assigned to denosumab versus, placebo to see if it can prevent breast cancer. And again, these are very large international studies with a lot of collaborators, but our goal is that eventually, right now, what we have to offer individuals with BRCA1 and 2 mutations to prevent cancers, our options are, removal of the breasts, removal of the ovaries. We also have surveillance tactics, but what we would really love is non-surgical prevention approaches. And again, that's aspirational right now, but that is the end goal.
We know that people who carry a BRCA gene face a higher than average risk of cancer, but that doesn't mean that they'll get cancer. Are we any closer to knowing why, say, 2 people who have the same genetic mutation carry the same well-identified gene that raises the risk of cancer, why one of them develops cancer and the other one doesn't? Do we understand that?
It's such a great question, and it's really important to talk about how we want to improve individualized risk assessment. If we knew, for instance, that someone wasn't likely to develop ovarian cancer before age 60, then we could wait to take her ovaries out. If we thought that someone was at a lower risk of breast cancer, again, we could wait on these decisions. So there are several things that matter here. And one is this concept of a polygenic risk score. What is that? Well, there are genes other than BRCA1 and 2 that impact cancer risk. And there are these tiny changes that we call single nucleotide polymorphisms, or SNPs, as we call them. And we know about over 300 of them now. And these individual SNPs only change the risk of breast cancer by the tiniest of amounts. Any individual one matters very little. But if you have all 300 good SNPs versus all 300 bad SNPs, it can identify people who are at higher or lower risk of cancer. And this is true in the general population, even in individuals that do not have BRCA1 and 2 mutations. But it also helps spread the risk out in BRCA1 and 2 mutation carriers. Now, how exactly we incorporate that into our clinical care is complicated. And with Dr. Offit and Dr. Robson at Memorial Sloan Kettering, we're really trying to answer this question of providing that information back to women to see how that changes their decision-making process. There are other things, the location of the gene mutation in, say, BRCA1, it has a minor effect on the risk of breast or ovarian cancer. And we do think that things like reproductive risk factors and other environmental exposures can impact risk. So we are hopeful that someday we'll have a better integrated model combining all of these factors to give individuals a better sense of their risk.
I want to ask you a someday question about your thoughts about the future of genetics and oncology. When you imagine the latter years of this century, do you think that there'll be lots of connections that have been made between specific mutations in various conditions? Or are we essentially talking about the more obvious conditions like breast cancer, which had been seen in families before anyone knew what a gene was? I mean, decades before anyone knew what a gene was. Is this approach to medicine limited to some obvious conditions?
It is such a great question, and it is a bit of a philosophical one. I'm not sure if you've ever seen the movie Gattaca, but it's a cult classic in the genetics community, and actually we're pretty close to Gattaca if we just flip the switch. We know about a lot of risk factors, genetic risk factors for cardiovascular disease, for diabetes, for cancers, multiple different types of cancers. But a key point is what you started with. Genetics is not destiny. There are very, very few genetic conditions which are what we call 100% penetrant. And by that, I mean that if you have a gene mutation, 100% of the time, someone gets that condition. One of those is something called Huntington's disease, which is a rare neurologic condition. But the cancer, for instance, BRCA1 or 2, it is not 100% penetrant. There will be individuals who have these gene mutations who never get cancer. So right now, our ability to sequence the DNA, that's the easy part now. We can do things like whole exome sequencing all of the genetic information, the coding sequences in the DNA. We can do that pretty easily. What we are less good at is putting all the connections together between the various types of genetic information and the various risk factors that people have to give them a good idea of what their risk is. And so we do have to be careful. Family history, as Dr. Offit mentioned, is very important. Even if you don't have a particular genetic risk, if a specific condition runs in your family, that's still very important. So genetics is not everything. Genetics is a piece. It helps us predict risk. And we need a lot more literacy, both for patients, but also for providers about how to use this information.
Dr. Domchek, thank you very much. And hang around, because in another 10 minutes, we'll take questions. And I'd like to hear more comments from all of our panelists. Then that's Dr. Susan Domchek, who is the executive director, head of the Bassler Center for BRCA at the University of Pennsylvania. We're marking Breast Cancer Awareness Month, and breast cancer is mostly, but not exclusively, a disease that afflicts women. And in fact, the BRCA genes lead us to men's health for other reasons. They can put men at much higher risk for prostate cancer. At Rabin Medical Center in Petah Tikva in Israel, urologist David Margel directs the center that he founded for male BRCA. Dr. Margel was with us last October as well and joins us once again. Good to see you. And first, if a man carries a BRCA mutation, what is the health risk to him?
So, as you said, the main risk is prostate cancer, but there are other cancers that BRCA germline mutations increase the risk for in men. One is breast cancer. It's about 100 times more than the general population, but still less than a woman, okay, in the general population. So it does increase the risk, but still the absolute risk for a man having breast cancer, even if he's a BRCA carrier, is low. There is risk for pancreatic cancer as well. And we are debating whether there's increased risk for other cancers, such as skin cancers and colon. We're not certain.
Well, it's remarkable. If a woman is found to carry the gene, I've been familiar with this, with stories of this, and her alerting her daughter or her sister. She should also be alerting her son and her brother. Men are equally carriers of the gene and also are at risk for carrying it.
Oh, that's for certain. That's a myth we need to get rid of. If there's somebody in your family that is a carrier of BRCA, the whole family should get checked, men and women. First, because increased risk of male cancers, but also for men that are carriers can move the heritage forward and also can pass it to their daughters and sons. So there is no difference. It is an autosomal dominant germline mutation. That means that if your father or mother is a carrier, you have a 50% chance, no matter where whether you are a man or a woman, to be a carrier. So if there is a BRCA mutation in your family, men should get checked as well as women.
I want to ask you about testing. Like a lot of men, when I have a physical, I have blood taken, and then I see lots of numbers, and my doctor tells me how good my grades are. And if I see a low number for PSA, which I learned stands for prostate specific antigen, that's good news, because a high score would be a warning sign of prostate cancer. Your center published a study about testing men with BRCA for prostate cancer, and made that PSA test seem a little less solid. Tell us about what you did.
Okay, so what we did in our screening study for men with BRCA, not the general population, but men at high risk for prostate cancer that are BRCA carriers, we used PSA as everybody, but we also used MRI as a screening method. No matter what the PSA, we sent all men to do an MRI of their prostate. Mind you, women do MRIs of their breast all the time. What we saw is that we detected about 30% more cancers using MRIs than PSAs alone. And we would have missed many of our cancers had we only relied on PSAs. So, and this is especially true for the young carriers. So if you are younger than 55, between 40 to 55, there's no reason to test for prostate cancer probably if you're younger than 40. But if you're 40 to 55 years old and you're a BRCA carrier, we now use MRI as a screening strategy, not only PSA.
What's your theory of what you found in that test, by the way? Is it that you're finding cancers that are simply too small to generate the amount of PSA that would show up in a blood test, or is it that prostate cancers develop differently than you'd thought, and maybe the relationship to PSA isn't as direct as you'd assumed? What's going on there?
So first of all, that's a great question, and we don't really know the answer. We know that PSA is not a perfect marker in any population. We did not do a control population, so I don't know what would happen if we test the general population and not BRCA carriers. But we did find significant cancers. So the cancers we found were not small, minimal cancers, but actually cancers that we can see on MRI. But we do think that among young men, usually prostate size is very small, And the PSA is a lot of time affected by that. So among young men, younger than 55, PSAs are very low, and sometimes you can find the cancer in those patients as well. PSA would not be helpful in detecting.
If in fact MRI screening is finding that many more cancers, and if it became a part of routine physical exams, how often should somebody, it's certainly somebody with the BRCA gene, how often should they get an MRI, do you think?
So our results of our study were also only for the initial round of screening. We are now doing a 5-year completion study. So patients who had an initial MRI and PSA was stable, we take them and do another MRI in 5 years. Hopefully next year, if you have me, I'll get the results of that study. But what we are doing in the clinically and not on study, is for patients with a stable PSA, we do an MRI in 3 years time. For patients with a rising PSA, we do an MRI if their PSA rises.
And I'm curious to hear about the sort of thing that Susan Domchek, the Dr. Domchek, was talking about. Once you do detect, say, a man of 55 who has prostate cancer, what do you do now? I mean, what are his chances, and how much improved are his chances over 10 or 20 years ago?
So first of all, prostate cancer is something that we can treat. We don't always cure, but even if we don't cure, they live for a long, long time, usually. For young, so treating prostate cancer is not an easy task. There are many, many options. One option for an early cancer, a Gleason 6 cancer, meaning a very, very small, non-violent cancer, if you may, is active surveillance, is monitoring the cancer. Now, many physicians, many urologists, many oncologists would be very scared to monitor an early cancer among BRCA carriers.
Why is that? Well, explain that anxiety to me.
Because it runs in two ways. First of all, the physician may be scared he's missing a window of opportunity to cure a patient. So this cancer can, in the physician's mind, because a person's a BRCA carrier, it might change very rapidly, and you might lose a window of opportunity to cure. The second is the patient. These patients, BRCA carriers, usually are very familiar with cancer. They at least have one member of their family who died of cancer. And that word for them is very, very scary. And telling them they have cancer and now you can monitor that, it's not an easy task to do. At our clinic, we do offer active surveillance for a Gleason 6 cancer. We now have about 25 patients we monitor, which is not very much, but considering this rare population, it's kind of maybe the largest prospective cohort. And we are not finding that they progress more rapidly or at higher percentage than other populations we monitor. But we do monitor them very closely. We do MRIs every year, we do biopsies every year, and PSAs every 3 months. So, and we're very happy. In any case of progression, we do offer them treatment.
Dr. Margel, I just wanted to ask you about one other thing, because you said it last year, you mentioned it, and it was one of the most memorable things I recall hearing. You said something very interesting about speaking of a gene associated, quote, with Ashkenazi Jews. Israel is obviously home to a great many Ashkenazi Jews. It's also home to a lot of Jews with origins in North Africa and the Middle East, many of whom are married to Ashkenazi Jews. There are also lots of spouses of Russian Jewish emigres who were not Jewish and who were Israeli citizens. You hinted at the notion that the phrase Ashkenazi Jew is becoming obsolete, at least in Israel. I mean, do you find that you have patients who wouldn't identify themselves as Ashkenazi Jews but have the BRCA gene?
First of all, there are other populations, Afghan Jews, there's a Yemenite mutation, but Israel, as you said, is a largely Jewish state, and very integrated. So my kids now do not really know what an Ashkenazi Jew means. They have friends who have no idea whether they're Ashkenazi or not. And they're all mixed marriages between different, sectors in Israel. So for me, this is a distinction that is disappearing. Ashkenazi Jew may be true in other places in the world, but in Israel, it's a mixed population, and I'm treating every person the same, and the Ashkenazi origin does not really change the way I think about whether I should or should not do a genetic test.
Well, Dr. David Margel of Rabin Medical Center, thank you so much. And I'd like to call back Dr. Kenneth Offit and Dr. Susan Domchek, and we'll turn to some questions, a couple of which have been submitted. First, a question to Susan Domchek and Kenneth Offit. What happens if genetic testing reveals, if it cannot, the BRCA gene in the pancreas? Can a person be helped, and can their life be saved? Would like to?
I'll start, and then Ken can chime in. I think what is being alluded to is that there is an increased risk of pancreatic cancer, particularly for BRCA2 mutations. That risk of pancreatic cancer is in the 7% range. It's smaller for BRCA1. And there has been, evolving data on whether or not pancreatic cancer screening may be of value. Currently, the NCCN guidelines, which is just one set of guidelines, but in the United States, it's the National Comprehensive Cancer Center Network guidelines. Dr. Offit and I both sit on the guideline committee. And recently, it has been added to the guidelines that if you have a BRCA1 or 2 mutation and you have a first or second degree relative with pancreatic cancer, that pancreatic cancer screening is offered, either using an endoscopic ultrasound, which is when a probe is placed down into the stomach and you basically do an ultrasound from the inside out to get a good look at the pancreas, or by using an abdominal MRI. And I think we're really still waiting for the data to show that we are saving lives in that case. But what we do know that advanced stage pancreatic cancer is remarkably difficult to treat, and that the chances of survival are greatest if it is caught early. And so we also have ongoing studies for individuals who don't meet those specific criteria. So Ken, I don't know if you have.
Ken Offit, Dr. Offit.
Yeah, no, I agree with that. And I would just add, with Susan Domchek said, to underscore also what Dr. Margel was saying about the MRI scans for the prostate. These make sense, but they should be done as part of trials, of prospective trials, to actually measure what we're doing, because as Dr. Domchek said, we really don't have the evidence that we save lives by doing these interventions. We would like to think that they do. In fact, here at Memorial, one of our eminent gastroenterologists is just retired, and we've been referring these cases to his registry here at Memorial. These cases meaning individuals with BRCA and other mutations at risk for pancreatic cancer who have been getting annual screening, generally MRIs. And after a decade of doing this, I can't tell you that we have cured or found a curable pancreatic cancer. Fortunately, we haven't really found people with advanced cancer. So as Dr. Domchek said, the risk appears to be modest, but we're continuing to enroll. I do think it makes sense to explore this type of imaging for pancreatic cancers and prove that it works. I've been at this for a long time. And I have had anecdotal circumstances of finding pancreatic cancers at an early stage, but it's a very, very difficult disease to cure, like a breast cancer with early stage. So it's there, and those guidelines, I think, will give individuals in the United States, at least, more latitude, right, to try to seek insurance reimbursement. And I asked Dr. Margel in Israel if there's that same latitude in Israel for MRI screening for pancreatic cancers there.
Dr. Margel, I assume that the yellow hand is your.
I can raise it. Yeah, I wanted to, because we do perform among them in the men's clinic, in the men's BRCA clinic, we do annual screening for pancreas as well. We now have, I think, almost 600 men who are 40 and above. We found 6 pancreatic cancers during our screening strategy using very simple tests. We do CA19-9, which is a simple marker, and abdominal ultrasound at first among men that have, the body habitus that can actually see the ultrasound, and men who are more obese are referred to MRI or endoscopic ultrasound. And all these 6 we did find were early, and all of these patients are alive now. So it's anecdotal, it's very, very early.
Yes.
But we're feeling we're doing something very, very good. I can't say I saved a life finding very early prostate cancer. I can definitely say I saved a life if I found a very early pancreatic cancer.
Really? And an attendee anonymously sent us this question for you. With or without the BRCA test, do you think a man with an elevated PSA but no other signs should have an MRI?
Yeah, definitely. The answer is yes. We used to do, if a PSA was high, we used to send to a biopsy. That is not practiced in Israel anymore. We send them to an MRI. That saves about 30% of the biopsies, unnecessary biopsies, and also helps us direct the biopsy to a location that is more likely to have cancer. So the answer is definitely, if there is a rise in PSA, you should be referred to an MRI and not straight to a biopsy.
Dr. Offit, here's a question that was submitted about COVID. With the existence of COVID, what impact does that have on people's decisions for BRCA genetic testing? I guess, are you detecting any difference that it's having on people's decisions for genetic testing?
Well, actually, Dr. Domchek and I were sort of comparing notes about this because all of our colleagues at our large centers had decrements in their volume. My wife, for example, is a radiologist, was very upset because all of her patients were missing their annual screening. And as you know, there's a large burden, right, that creates on the system and a concern. But in genetics, you never want to say it was a good thing, but there were some very positive spins that came out of this pandemic from just the functional sort of logistics of things for patients. Number one, we were able to go do 100% telemedicine like we're doing right here, right? Mm-hmm. Talking to you.
Yeah.
And then at the, after the conversation, sending you a spit kit. Typically, it would have taken 2 years for us to have our laboratory approved in New York State to change from blood to saliva. Because of COVID, it was approved in 2 weeks. So no more blood testing, telemedicine. So our volumes went down 7%, whereas most of our centers, they were down 30%. And we are now up 33% from prior to COVID. So not quite sure what the explanation for it is. I would just say my own impression is that the explanation is just simply convenience. It's just terribly convenient I had to leave my clinic today, as you know, to do this. And, the last person I was speaking to is in her car. Mm-hmm. She pulled over to the side, at least. Sometimes they don't, Makes me nervous.
I hope that's a violation of traffic law somewhere to have your oncology appointment while driving. Yeah, go ahead.
I don't want to get into this. It's a sensitive point in our family. But in any event, it's made it terribly, terribly convenient for people, and in a good way. And I think, so that's my perspective. I'm curious with Susan and David, what your impressions have been in other cities and other cultures.
Yeah, I'm very interested. Why don't we start with Susan Domchek? I mean, we're now we're pretty deep into the pandemic, and here's hoping we don't have any more programs about the pandemic next year. We'll have one in a couple of months, but what effect has it had on your practice? And are there things like telemedicine that we found a real tolerance for that,
Well, I think that even before the pandemic, we research that was done by one of my colleagues, Angela Bradbury, and by others in many different places, showed that telephone or telegenetics, it worked. And the reason we couldn't do it was because we didn't get paid for it. And the United States is a weird place where, it's fee for service and all this stuff. And so in other countries, you can choose the most efficient way to do things. And for us, it's not quite so easy because we do have to actually pay salaries.
If I go to see you in your office and I have an appointment with you, that's a claim, and maybe I get reimbursed all of it or some of it from my insurance. But if I call you up, if I get a call from you at the end of the day, that's on the house. That
was before COVID, right? So, and then all of a sudden during COVID, many restrictions were lifted, and our volume skyrocketed. We were testing so many more patients because they could do it from their couch, and everybody would prefer to do things from their couch. And also, people, I think there were definitely people who had honestly a little time on their hands, so things that they put off. We didn't have any time on our hands, but there are some patients that things had slowed down a bit. And so they got it done. I very much hope that in the United States, some version of telehealth maintains, but we're already seeing things shut down a bit. And so, I'm right on the border of New Jersey and Pennsylvania. So currently we can still do follow-ups, but we can't do news unless you're blah, 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 blah. So it's already getting more complicated. So we are very hopeful that some of this will go away. Having said that, we definitely saw people who did not get their screenings done. And I'm also a, card-carrying breast medical oncologist. I have been giving more people chemotherapy for their breast cancer right now than I have in a long time. And that's because I'm seeing more patients with positive lymph nodes with larger tumors who had put off their screening. And it turns out that breast cancer, if you don't find it, it's not that it's not there. It's just that it comes later. And Ken's wife probably has seen a similar phenomenon in the radiology clinic. And that is just somewhat heartbreaking, is that these patients who had stayed on time with their screening may not have needed the aggressive approach that we need to do.
And David Margel, the impact of COVID on your practice of medicine in Petah Tikva?
So I think Susan has a very important point. So new patients now come at the same rate they have, maybe even an increased rate, because we do telemedicine and we offer a lot of things we wouldn't have had in their, at the leisure of their home. But patients that are used to follow screening guidelines, so they used to do their annual screening, a lot of them miss that. And we are finding cancers at a more advanced stage than what we used to before. So that's the distinction, I think, that COVID may have caused. And hopefully it'll go away, because we're going to deal with this for many more years. So patients and the whole, medicine world, we have changed, we have evolved. We do offer a lot more out of, in the house, but screening and imaging, we can't really do it from home, and they still need to go to the hospital.
Yeah. As we're nearing an end here, I'd like to hear from each of you in conclusion about what's some big question about all this, about cancer and genetics. What is a big question that is not something that we may get to answer in the 22nd century, but something, the answer to which might be at the horizon, that in the next few years, people in your fields may be able to answer. What's the question? What's a big question that keeps you awake at night, wondering, when are we going to figure this one out? And we'll start with David Margel.
Wow. So first of all, a great question, but so many difficult questions we need to answer. I think the best question would be prevention. So we're talking about screening and early detection. We're talking about better treatments. But if we can prevent even one cancer from happening, we'll probably do much more than treat 100 cancers, right? Some of it may be chemoprevention, but I can kind of doubt that PARP inhibitors would be given even to healthy BRCA carriers. How long, there's so many open questions for that. But how would lifestyle change? Maybe a triple pill of statins, metformin, and aspirin may be helpful. All these things, I think, can change and can affect if we find even a single way to prevent even a small proportion of these cancers. So prevention for me is most.
And Susan Domchek?
I'm a big fan of figuring out better non-surgical prevention strategies. And I think to layer on that, we need to figure out whether, we should call this disease interception, and whether we can detect a cancer at such an early stage that it truly is always curable. And there are a lot of different things coming down the pike. These, what we call liquid biopsies, these blood tests that might detect cancer early. Right now, they're not ready for prime time, in my opinion, but the technology is getting better all the time. So it may be this layered effect: super early detection, prevention options, and identifying people at risk.
And Dr. Offit, Ken Offit.
Well, I was actually chatting with my daughter, who's a medical student, who wants to know the same thing, right? Because she wants to pick what subspecialty to go into for the future, where's all the action? And so, we talked a lot about, these kinds of ideas, the David and Susan, the silver bullets, targeting prevention by understanding the biology. Radiology, interestingly, has moved more in the direction of being able to actually image at a cellular level, and this could lead to early detection and intervention, molecularly targeting, as we understand more about the biology of these susceptibility syndromes. That's what I'm actually doing in our lab at Sloan Kettering right now. That's pretty much not what I planned on doing, but we're looking at trying to target one particular genetic pathway. But what I would come back to, and it's what I'm actually spending most of my time doing now, is if we just go to sea, with the fleet that we already have, the ships as they are, and everything with the technology that we have, as we started, we can make a major shift by just blending the ingredients, that you discussed in the context of this program today. The telemedicine, the outreach, the internet, education, and just with the prevention, just with even the surgeries that we had in the last century, right?
Mm-hmm.
And the MRI screening, and you heard about David's use of the MRIs. If we could just get this information to everyone, and this can happen even in the course of a mature career like mine, we could actually make the major difference in prevention of these common cancers without any new silver bullets. So I would just focus on that as my sort of aspiration at this point, that we can maximize the gains that we've already made without waiting for new spectacular ones. Get the testing, get the information, and follow through with the screening and prevention. And we the Ashkenazi population will disproportionately benefit, but because of our hereditary burden, but all will benefit because the burden of these hereditary cancers is universal. It's everywhere on the planet.
Ken Offit, thank you very much. And thanks to all of our guests, Dr. Kenneth Offit, Dr. Susan Domchek, and Dr. David Margel. Many thanks as well to Joshua Plout, Nate Bonzani, and Roni Giuliano, and Sarah Lipoff from American Friends of the Rabin Medical Center, and our technical director, Sam Lanetta. Our program sponsor is the American Friends of Rabin Medical Center, which is a 501c3 national charitable organization in the United States. It represents Israel's largest hospital, Rabin Medical Center in Petach Tikva in Greater Tel Aviv. The website for the organization is www.afrmc.org. Join us next month for COVID Revisited, Are We Safe Yet? With special guests, Dr. Erwin Redlener of the Pandemic Research and Responsive Initiative at Columbia University, Dr. Nahid Badilia of Boston University, Dr. Kavita Patel of the Brookings Institution, and Dr. Michael Drescher, Head of Emergency Medicine and Trauma at Rabin Medical Center. And after that, the following month, Combating Anti-Semitism's Resurgence. I'm Robert Siegel, and this has been Global Connections, Navigating the New Normal. See you next month. Stay healthy and stay safe.